a roundtable on safe consumption sites. We've invited people who've operated and researched safe consumption spaces to talk about drug user run versus more medicalized sites, and about how to center the experiences of people who use drugs in these settings. I'll ask the roundtable participants some questions and they'll answer them. They'll also be able to respond to each other's responses if they're moved to do so. We'll also save some time for questions at the end. So even though you'll notice that the chat is disabled, we encourage you to type your questions into the Q&A box. Unfortunately, we're not offering translation services for this event, but we will be starting with the second session. So today I'm here with Mimi Cove, Marie Jaffret Rustid, Thomas Kerr, and Ara Roig. First, we're going to go around and ask each of you to introduce yourself with your name, pronouns, and your affiliation, and just a little bit about your past or current experience operating or studying safe consumption sites, a little bit about your journey in this work and motivated you to do it. So, Ara, why don't you start and then pass it on to another roundtable participant and so on.
Hello, thank you so much. So glad to be here. I'm Aura Roig. I am the founding director of Medgeneres, that is a safe space for women and gender non-conforming people who use drugs, surviving multiple situations of violence and vulnerability. That is based in Barcelona. And about my past, I am an social anthropologist, currently working in my PhD, and I was in charge to design and implement the first programs for people who inject drugs also in Colombia, and also with experience in Canada and other places. From me then.
Thank you.
Do you want to pass it on to somebody else, or should I choose?
Sorry. Yeah, Marie, for example. Glad to see you also.
So, hello, my name is Marie Geoffrey Roustid. My pronouns are she, her. I'm a sociologist, a research fellow at the French National Institute of Health and Medical Research in Paris. I'm very, very happy to be here with this wonderful panel. I'm here because I was one of the PIs who evaluate the drug consumption rooms in France. And I was nominated by my research institution and by the French government to do this evaluation. It includes an ethnographic work and a cohort survey. And it was an honor to be involved in this research process, but also a big responsibility because the French government was waited for the result of this research to decide if they will or not disseminate this harm reduction tool. And I will give the floor to Mimi.
Oh, thank you very much. Hi, my name is Mimi Cove. My pronouns are she, her. My affiliation is with Who's Corner Anyways, which is a mutual aid group here in Western Massachusetts, which is for women, people that identify as women, for and by survival sex workers. So my past journey has been a long and treacherous one. I basically had experience running some underground safe consumption spaces, especially focused around women and women's use. I've also volunteered for some temporary safe consumption spaces at, so we say national and international events. And my motivation for doing this work, I think, is similar to all of us, is just that this has been going on now for so long. And we've lost so many people, and the evidence is there. It's and that we've had lives lost and too many years gone by. And so it's about time that we get this going in the United States, is my feeling. So that's my motivation. Oh, and I get to pick somebody. I'm going to Katie Simon.
I'm sorry, Thomas, would you like to introduce yourself?
Or
Sorry.
Thomas.
Sure. Good morning or good afternoon, depending on where you are. I'd just like to start by acknowledging with gratitude that I'm speaking to you today from the traditional and ancestral territory of the Coast Salish people, including the Musqueam, Tsleil-Waututh, and Squamish nations here who have stewarded this land for centuries. So very grateful. My pronouns are he, him, and I'm a professor and head of the Division of Social Medicine in the Faculty of Medicine at the University of British Columbia, and I'm the Director of Research at the BC Centre on Substance Use. I've been involved in supervised consumption work now for almost 25 years. In 2000, 2001, I was contracted by a coalition of activists and healthcare providers and people who use drugs to develop the first proposal for a supervised consumption site in North America. A few years later, when that opened, I helped lead the evaluation of Insight, North America's first supervised consumption site, and have since been involved in supervised consumption site research in a number of settings internationally, and have conducted a lot of feasibility work across Canada and elsewhere. For me, the motivation is clear. It's to save lives and bring dignity to people who use drugs. Obviously we have a huge amount of work to do still, so it's not hard to to keep up for this. Thanks. Am I passing it on to anyone, or nope, that's it.
Nobody left. So now I'll segue to questions for the roundtable participants. And the first question is, so there are many labels used to describe these spaces. Some examples include safe consumption sites, safe injection sites, safer consumption sites, supervised consumption sites, overdose prevention sites, medically supervised overdose prevention sites, et cetera, et cetera, et cetera. Which of these labels do you use? And could you talk a bit about why you use the language that you do and what you think about other terminology that's in use? And I also know that there are issues of language here with this international group, but when you answer, you can also feel free to sum up how these issues of connotation and politically fraught semantics might play out in the language you use most. So Thomas, if you don't mind starting us off on that one.
Yeah, I was intrigued by this question because I certainly remember 20 plus years ago when we started talking about establishing a site in Vancouver, and within our group there was a great deal of discussion about how to be very strategic and come up with a politically appealing name. And I think the first thing we landed on was health rooms. And man, did we get hammered. The people who are opposed to these things say, don't play word games with us. We know what you're talking about. You're talking about a shooting gallery. So, then we had to spend a whole lot of time. We kind of set ourselves up for a bit of a fight there, explaining why it wasn't a conventional shooting gallery and it was something else. So in my time, I've seen them become safer injection sites, supervised injection sites, now supervised consumption sites. And I've just watched the language evolve. And I've also watched other settings struggle with trying to come up with a name that's going to, minimize political opposition. But in the end, you know what? I think people figure out what these places are all about. In some ways, it maybe doesn't matter as much what we call them. But, I do think there's some sensitivities. I always struggled a little bit with the supervised part of it when it's talking about the healthcare system supervising people who use drugs. I always preferred the language that I hear local people use, which is safe sites. It's a safe site. And the supervised part of it, they can take or leave. So, I think it's been challenging coming up with language that's kind of held. It seems to just continue to evolve, and I suspect it will stay that way.
Mimi, do you want to follow that up?
Yeah, I think I agree with a lot of what Thomas said. I'm a realist, and so I tend to just try to read the room and kind of find the easiest way around who I'm speaking with and what will speak to them, right? So if I'm speaking to a group of drug users in my community, we're going to use a different language than if I'm speaking to the business union, where we're trying to put a safe injection facility or a health room or whatever we're going to try to call it. But thinking about what Thomas just said, it kind of brought up something for me, which is, long ago when we all started in this, we started with needle exchange, and how much has that evolved over the years into what we call it now. And a lot of us still call it needle exchange, and we know what we're talking about, but certainly it includes many more options and services, and it encompasses a lot more than just a needle exchange, right? But old frontline workers like myself, I think we tend to have a shorthand created out of a culture that started around what we had a chance to do. And unfortunately, that was mostly white injection drug users just trying to survive. And thank God now the conversation is expanded to include a much larger group and a much more diverse group. And that includes smokers, sniffers, people of different races, people identify with different genders, things like that. So on one hand, I definitely agree with what Thomas says, is like the gig's up, people know what we're doing. And so do we go that route and just say, this is what it is, everybody knows what it is? Or do we try to kind of couch that conversation? And so I think that's an ongoing and a kind of a dynamic discussion. But I do think there's a generational divide here. That definitely, but that includes, also not judging people for the language that they've used and that they continue to use. So in mixed company, yes, overdose prevention site as opposed to safer consumption site. I think nobody that I want to talk to can be opposed to saving people's lives from overdose. But I definitely agree with what Thomas said about the supervised aspect of it. And that's something I hadn't thought about. And this is coming also from an EMT and a phlebotomist, as well as a frontline worker, that I don't necessarily like the connotation of medically, the medical, the verbiage of medically supervised, or even using medical language, in so much as I think it creates kind of a dichotomy. It creates a false hierarchy. It creates a divide, not only among each other, but the people that we're trying to support, right, that come in. So I don't know if that quite answers the question or brings up more questions, but that's just kind of my feelings on that question.
Aura, do you want to talk about next?
Yeah, in our case, because in Barcelona have been supervised a consumption room, really medicalized for around 30 years. Then when we opened at Mediciner, we decided that we are not a consumption room. We are a social center where people who use drugs and women who use drugs come to do a lot of things, especially workshops and activism, etc. And we also include the possibility to use in a safer way any of the drugs that the people want to use. Then they can drink alcohol, they can take psychiatric meds, also they use methamphetamine, they smoke whatever they want to smoke, including methamphetamine, crack cocaine, etc. And also we have a place to inject in a safer way. We talk about accompaniment during, not supervision, but accompaniment. And who do this accompaniment can be wherever. Sometimes gonna be a nurse because it's easier to find a vein for them and to support with finding a vein. But sometimes it's the lawyer, because we know that is the only moment that the women are there and have the calm to be able to tackle other issues in their lives. Can be the social workers, can be another a friend that is there, that the women feel safer. Then it's more, and I don't know how do you say, like the power room where the women put the makeup is how we talk about that, is that the power room for consumption is like
Mm.
in Spanish makes more sense. Sorry, because I wouldn't say, but we talk about el tocador de consumo for the ones that are in the room that knows about Spanish. And for us was really important, because one of the things is that we don't want to focus in the use of drugs. We just want to break the barrier that makes the people who use drugs don't be able to use other spaces. But it's related with the activism that we are having. Like, we don't want to have more, to see harm reduction as a isolated strategy for people who use drugs, but more as like, yeah, the people use drugs in general, then they have to be allowed to use whatever service they want without being expelled or barred because they are using drugs. Then this was more our perspective, and yeah, and I think that this is the focus.
Mhm.
Thanks, Aura. I've always admired how you frame Metzineras' function in a broader, more community-centered way, rather than focusing, solely on the safer consumption aspect. Marie, would you like to briefly address the question also?
Yes, in France, it's very different compared to North America, because we never use a label overdose prevention site. I was very surprised when I arrived in North America and when I hear about it. We use a label salle de consommation à moindre risque in French, which means rooms to use drugs with less harms. And we don't use this label overdose prevention site, because hopefully we have a very low overdose rate, less than 500 deaths per year for a country of 67 million of inhabitants. So the difference is explained by the dissemination of harm reduction in France. So that's the first point. The second point is that in the media, the label drug consumption rooms that we use in the scientific area or in harm reduction area is never used. The media discourse and the political discourse, they use a label shooting gallery. And that's really a pity, because this label reveals all the misunderstandings that exist about safe consumption site in the media, in the political discourse. So we need to improve the knowledge about what are safe consumption sites in practice and how they operate. And the last thing that I also want to share with you is that people with living experience in France, they say, I'm going to the room, only the room. And I think that it is very meaningful, because it reveals that this room, this place, considered by people with lived experience as rooms where they can be protected from the violence of the street, from the violence to be exposed to other people when they are reduced to inject in public space. So this, I like this word room. I'm going to the room, because that's my place, that's my room where I can be protected.
Mm.
Thank you so much, Marie. I remember when you brought up that point in a practice session, it was so arresting to me, because that, the language of overdose prevention isn't even necessary in a French context, because for a drug user in the United States, the overdose epidemic is what water is to a fish. Does anybody have a brief response to anything any of the other roundtable participants said? Really quickly, or no? If no, we can move on. Sorry.
I'm just interested, Thomas, because we started off from going from like the gig is up, they know what we're talking about, right? In North America, to a couple of these other situations where they're saying, it's our room and it's protected in different labels for these places. what do you think, what's your take on that? Is it just something that's dynamic? Is it different from location to location? Do you think it's something just, you know,
Yeah, I imagine it is.
closed-
I think it is dynamic, and I think also, we have to differentiate between the names and the meaning ascribed by the people who are utilizing these facilities versus the people out there who wish they were all non-existent. So I think what I'm saying is that, when we try and play, language games and come up with names to kind of appease those opposed to these facilities, I don't think it works.
Mhm.
But I still think, trying to search for something meaningful, whether it's overdose prevention site or the examples used in Spain, I think those things still matter and we should pursue those. And ultimately, I think it has to resonate with the people who use these facilities. And I think we have to be mindful to some of the issues that contribute potentially to further stigmatization, or over control by the medical system by talking about medically supervised and these kinds of things. So I think there's a lot of nuance there.
Thank you.
When Marie was speaking, I also thought of the fact that it's also another really fascinating international similarity, because in underground contexts, I've definitely heard many of us who use drugs simply just call them the room. And I'm just going to move to the next question. And the next question is specifically for those in the roundtable who've operated safe consumption sites. So in your work implementing safe consumption sites, what's been the most rewarding thing? And what's been the most challenging thing? Mimi, do you want to start us off with that?
Yeah, I think that's a really interesting question, Katie. My first go-to obviously was to say, reviving somebody from an overdose, but I think there's more to it than that. One, I think that's also a double-edged sword. I think the infrastructure that we have here now, especially in the underground spaces and the grassroots, is we lack the infrastructure and the support for the people that do revive people. And it's a traumatizing thing on both sides. So although it's a very rewarding and wonderful experience, it's also a scary experience. It's a traumatizing experience. There's secondary trauma. There's a lot wrapped up in that. And, we're still working on the baby steps of getting this going, never mind the follow-up with what happens following an overdose. So I think what I would say is that the most rewarding thing is seeing the community come together around this, and seeing, especially among the women that I've worked with, the not just the community that's created, but the empowerment that these rooms give them. I'm thinking of a woman that I've worked with, who was, she was of the community, she was Latina, she was a survival sex worker, she was HIV positive, and for a number of reasons, she lacked confidence, she lacked people that were willing to work with her and give her a chance. And this woman was, a phenomenal phlebotomist. She was just naturally gifted at working with people, at putting them at ease. And one of my greatest experiences was getting to work with this woman and seeing her kind of come into her own, and get to work with people and explain to people different, do this, don't do this, try this, don't do this, and see her become more part of the community, and respected as somebody to go to ask questions for. So around this, however we look at safe consumption and overdose and things like that, there's something else that's going on under the scene, and below what the undercurrent that's going on, which is what I think harm reduction is at its base, which is creating this community. right? And especially among women, which are often left out for a variety of reasons in these services. So yeah, I think I'm going to go with that it's creating community and giving and empowering people that don't usually find themselves in those positions the chance to be in those positions.
Or would you like to address the question?
Yeah, for me it was really, really similar, no? I think that to have a place that is the first house for most of the women that are coming has been really important. A place where they feel so safe that they can share um, strategies of survival that they have in the daily life, not for the drug use, but for sleeping in the streets, for doing sex work, for mental health issues, like just to have this place where they can talk about everything and to share and build this mutual support and solidarity has been amazing. And also how it has been accepted by the neighborhood. Like we began in the neighbor being like we are part of the community, like we are living in the neighborhood, working in the neighborhood, then being accepted like one of the important part there, and also see how these women are participating in a lot of the activism and community activities, like I don't know, against gentrification or for the 8th of March with the feminist movements, or with it has been the most amazing thing. And I think that um, to give the opposite thing, no, when we began, we thought that we will support women to navigate into the system. And one of the most frustrating things is that there is not a system where they can navigate. Then we become the only place where they can be. Then now we are like 400 women when we were not expecting so much at all. 50 women every day in a really small space. Like we are like a double room or a little bit, like it's really, really smaller space. Then to have to handle with everything by ourselves has been really, really complex and difficult. And yeah, it increased the violence also and the conflicts because we are really small in a really small place with 2 showers and everybody wants to take a shower and all these things, no? And another thing has been to find a team that is able to do this accompaniment with in this horizontal way, no? Because finally we go from different backgrounds, some people from the university with a lot of studies but not experience and whatever, and just to make sure that women are still in the center and are them who are running the place and who have to make the decision, and we have to be in the backstage just trying to make this possible. Has been a challenge. Is being a challenge.
Thank you, Aura. I very much relate from my local organizing experience, with the experience of having a lot of women in a very small space, trying to access a limited number of services and just gamely doing our best to get everybody what they need. The next question is for the researchers among the roundtable participants. So in your work studying safe consumption sites, what's been the most unexpected finding? And Marie, if you don't mind starting us off on this one.
Oh, it will be difficult to choose only one, but the first one was related to media analysis. So when we began the evaluation of drug consumption rooms in France, we did a media analysis, and I was very shocked by the results because the voices of people with lived experience were totally invisible in the media. So people with lived experience were represented 20 times less compared to politicians and 5 times less compared to residents. And it was very shocking because people with lived experience, people who inject drugs, people who smoke cocaine, crack, and who attend drug consumption rooms are people who are the first concerned by drug consumption rooms. They attend these rooms, so they know what are these rooms, and their voices are totally invisible in the media discourse. So that was the first unexpected result that was very shocking. And the second one was that is also directly linked to the media analysis, and when we compare the media analysis and the ethnographic work. So in the media analysis, there is quite only voices of residents who are totally opposed to drug consumption sites. And when we did our ethnographic work, when we did semi-structured interviews with residents, we showed how diverse the experiences and the discourses of residents are. And we also see that a majority of residents were more in favor of drug consumption rooms. And also another important result from the residents' discourse from our ethnographic work is that even for opponents, the discourses about reveals more fears about precarity, fears about migration, and less fears about drug use in general. So all the discourses were against drug consumption rooms reveals other aspects of stigma linked to drug use and social precarity and migration. And the discourses of residents were also revealing that some citizens felt being abandoned by the state because they live in displaced neighborhood, and sometimes it has nothing to do with drug use.
Thank you, Marie. So moving to our next question, and I'm going to attempt to merge it with one of the questions in our Q&A, noting how little time we have left. So next question is, how do we reconcile different objectives like public order, public health, social justice, and pleasure, all of which are objectives that safe consumption spaces are created to achieve when many of these objectives conflict, or at least are depicted as conflicting? And grounding that kind of really abstract framing of that question into a more grounded question, I will read a question from an anonymous attendee saying that organizing efforts in the US need to shift tactics. I don't think the political climate has ever been this polarized before. So my question is, what does that look like? And I guess, you know, combining that question with all of these different themes of public order, public health, social justice, and pleasure, and how they're evoked in our organizing tactics. If anybody wants to start us off on that, maybe Thomas?
Okay, that's a tough one. Maybe I'll just sort of riff off Marie's response to the previous question and try and link here, because for me, the most unexpected finding is that despite the fact that researchers around the world have produced dozens and dozens of studies demonstrating the benefits and the lack of negative impacts of these types of programs, we even have 3 well-conducted, published, peer-reviewed, systematic reviews in settings that are considering these facilities. We end up having the same silly debates. We act like as if there is no evidence, and I think nowhere is this more pronounced than in the US. So we hear these comments like, oh, this is enabling drug use, this is going to increase crime. Well, guess what? We've already looked at this. It's been looked at all around the world. The question of public order, there's very well conducted studies in Canada and Spain and Australia that all show the same impact using different methodologies and different settings, that these facilities don't actually make public order worse. Why on earth we would be prioritizing public order over saving lives is a mystery to me. You know, I think life is a lot more sacred than litter on the streets, and we need to get over that. But I think it's a tough one. You know, we always fall into this trap when we're trying to advocate for the implementation of these facilities, because again, we keep returning to these same silly debates. And, you know, the reality is, I think that if we really want to get to saving lives, sometimes we have to entertain these concerns and address them. And that's where I think we just, you know, we have to keep promoting the evidence and, you know, pointing out that, you know, really if you know, you're concerned about public drug use, then what you want is a supervised site or a safe site or whatever you want to call it in your facility. But again, I think, you know, we have to prioritize health and social justice over these other concerns. But again, I realize it's often a challenge. But you know, hopefully at the end of the day, we can draw on a lot of the good evidence. You know, I think that you know, in some settings, there's no more serious academic debate about the merits of these facilities. That's certainly, I think, how it is here in Canada now. But it's very frustrating, having worked in this area for the last 20 years, to see these same debates and arguments rehashed over and over and over again, as if we have no experience with these facilities. And then, you know, think about the European experience. Like, how long are we talking about now? You know, like decades, but people act like they don't exist.
Aura or Marie, would you like to follow up on this question of different objectives that are sometimes seen to conflict, and or how we frame organizing tactics that can really work in a US context, or in any context, given the way that people leverage these different objectives to be seen as conflicting with each other?
Yeah, for sure, for us, it's not a conflict between each other. No, public order is to have house, to have access to hospitals. This is public order. Other things are disorder, and is not. They are not cause for the people who use drugs, but because an injustice system. No, then is social justice is a parallel thing with public order. Then, and also for me, it's difficult to talk in Medicineras about pleasure, because I talk more about wellness and how people is trying to feel better and to improve their mental wellness, physical wellness, emotional wellness. But talk about pleasure is more related with recreational drugs, and in that sense, and in our case, is more related with the multiple situation of vulnerabilities of sleeping tendencies, the suffering and the trauma. Then talk about pressure sometimes is something that goes really far away of the reality of the women that are coming, or how they are living their own drug use a lot of times. Then for us, it's like this kind of equilibrium is sometimes is complicated, but also we took away the focus on just health, because one of the things in Europe has been that the harm reduction strategies have been always focused on HIV, overdose prevention. And what we found is like 30 years later, we have a lot of situation of exclusion that are chronified, and then the people is alive, but they are not living, they are surviving, they are in a surviving mode. Then we try to go to the structural causes, and they are not just health causes, they are social again, no, is housing, is to end the stigma and the discrimination, etc. Then we try to open the view not just to the health system or the social control, but talking about human rights in a more general approach, and also about patriarchy, no? Because a lot of the women are there because the violence that comes from the patriarchy, including their sexual and emotional partners.
Yes.
In fact, and another thing is like, sorry, I want to end with that. One of the things is that we are not pending from the drug services in Catalonia. We are pending from the feminist department. And this has been really a key issue because for the first time it's recognized that we are not talking about drugs, but we are talking about violence.
Perhaps to continue about Europe, in my country, France, there are a lot of false opposition about drug consumption rooms. For example, some people think that if we focus on public health, we will not have a result about public order. And I think that public order and public health and social justice are very linked together, because if you allow people who inject drugs to attend drug consumption rooms, they will improve their lives. And if they improve their lives by attending drug consumption rooms, it will improve also the lives of residents. And some residents think sometimes, and some politicians think, that if you give a room for people to inject drug, it will increase the number of people who are in the streets, but that's totally the opposite. So that's why I think that this opposition between public order and public health is false, because that if you give more dignity to people, it will be an improvement for people with lived experience who are stigmatized, and they would be less stigmatized because they feel being respected when they are attending drug consumption room with no judgment on their practices. But you will also improve the society in a whole, because people with lived experience will have a place, will be respected as citizens, and that will be, and that's why I think that drug consumption rooms have also the potential to become an instrument of civic cohabitation between residents and people with lived experience. And it's also a way to attend and to achieve more social justice for people who inject drugs.
I love the way you all just debunked these false dichotomies, and Aura in particular. I really enjoyed how you made a complex investigation of what pleasure actually means to people who are multiply marginalized and vulnerable. But I would just say really quickly that, I think the pleasure in the context of being multiply marginalized is very rarely discussed. I think even in the context of trauma, pleasure still has a place in people's lives, but the pleasure of people who are incredibly marginalized is so very rarely discussed or thought about. Anyway, I did want to just segue to the last question, which I'm asking you all to respond very briefly to. So what do you envision as a utopian future for safe consumption sites? And does your utopian future for drug use include safe consumption sites at all? Mimi, you want to start us off with that one?
A long way down the road for the US, I would say. My hope for it is just a large slate of choices put forth by drug users, by the people that are affected, that know, not by what you were saying, by politicians, not by the media, not by the people that don't understand this at all, in my opinion. It would be housing. It would be doors that locked where people are safe. It would be community. It would be empowering the woman that I was talking about so that she can go to the deep south and she has the confidence and skills to know that when she's by herself, she can revive somebody and she can start her own, whatever we're going to call it, her own community, her own room, where there's no value. You know, it encompasses everything. And it is especially for me, one of the things I think we didn't talk about, but it encompasses the lack of law enforcement and privatized prisons, and you know, going after our people and our communities for that as well. So it involves so much. I'm gonna just there and let you guys go.
Marie, do you want to follow that?
Perhaps I think that one important thing for the future will be to involve people with lived experience in the design of drug consumption rooms, and also in the management of the drug consumption room, to be sure that we have services that are more adapted to their needs. Another thing that is very, very important for me is to highlight the voices of people with lived experience, because as I just said, they are silented all the time. And I think that it's very important to highlight their voices, their experience, their narratives. And the last thing that I think is very important is to consider that when we speak about residents, people who live in the area, it's important also to consider that people with lived experience, when they are living in the street near the area where drug consumption rooms are implementing, they also need to be considered as residents themselves. And the public space need to be shared by all the people who live here, even if there are no roof under their head.
Aura, do you want to give us the last word on this?
Yeah, I think that they should disappear, because we have the right to put whatever we want in our bodies and in our minds. Then we have the right to use whatever we want in a safer way. Then if we take away the drugs as a core thing that avoid the real problems, and we can focus on the structural causes of inequality and discrimination, we don't spend a lot of money in stupid things, and we really can focus on what we need. That is like social justice and a place where we can be safe, whatever it means for everybody, no? In that sense, then drugs for me shouldn't be the center anymore. We should focus on the people, and if they use drugs, and also they do a lot of other things. Then to take away this label as a main focus, and really focus on what is important for everybody. If it's drugs, we're gonna support with that, but we need to have a more holistic view.
I just wanted to mention really quickly before we move to Q&A, something really striking that Mimi said to me when we were talking about this session, that, you know, even in a utopian world, you know, some people will never be satisfied with whatever forms of housing are available, and they deserve to be safe. That younger users will always be looking for community education, and that some people, you know, enjoy using in public settings. We just wouldn't have to offer them as this broadly applicable stopgap to the overdose epidemic that we now have to, in the way that we now do. And so now I did want to move to questions and answers, and Ryan will bring up some questions that have been put into the Q&A box.
Hi, everyone. Thank you so much for the thoughtful questions. We'll try to get through as many as we can, though noting we're running a little bit tight on time, but appreciate all the enthusiasm. One really thoughtful question put to the group is, how do people feel supervised consumption sites have done in terms of accommodating and providing a safe space for BIPOC, 2SL, GBTQ plus women and other folks at the kind of intersections of multiple structural inequities? And maybe just to add to that, as to what do folks feel that sites could do better so as to provide a safe space and ensure cultural safety and care and support?
I'm not sure if I understood well the question, but to open a place where for us has been really important, that is a place just for non-men, not just for women, but for non-men. It makes a safer place where people can share the different experience that they have, and also not focus on the drug use, but in all the rest of the things and whatever is important for the person has been a key issue in that sense. Also to build a really different participatory spaces where the people can bring the decision, not just including the women and gender non-conforming people and non-binary, sorry, because my language sometimes is more limited in that sense, but have different ways where the people can participate, like in the staff members, in the making decisions, but also like doing the workshops for the ones that know how to do workshops, or different meetings where they can really take part of the design, the implementation, the monitoring, and the evaluation of each of the action is important, because in that sense we can adapt the different heterogeneities, all the heterogeneity that we find in the place. That is huge. Like,
Great, thank you. One thing certainly striking about the US in comparison to places where a lot of work has been done on this is obviously gun violence. And there was a question put in terms of what can be done to ensure safety in the sites, and how they can navigate their relationship with law enforcement, but also maybe a question as to how we can intervene to address that more broadly in the context of how we provide harm reduction supports. Thomas, maybe pitch this to you in part because I think there's a really compelling Canadian example of what can be done to address getting crime out of substance use in terms of directly providing folks with things they might be using.
Yeah, I mean, I think that this raises a whole question about prohibition and the drug war itself. And let's not forget that this series is about dismantling the drug war. And I think one of the things we need to do is to look towards something that we're starting to work on here in Canada, which is ensuring people have access to a safe supply of drugs of their choosing. And I'm not talking about just providing medicalized opioid agonist therapy, which we know attracts a very small proportion of people and retains even fewer at 1 year. We recently had some data in Canada showing a 16% retention rate at 1 year. Sadly, there's a handful of, physicians in Canada anyway, who strongly oppose to safe supply. And basically their solution is to offer more opioid agonist therapy. So just more of the same. And it's really not a solution, but I think there's a huge opportunity to move towards more regulated models for substance use, which will really help address some of the crime elements, and importantly, reduce a huge amount of risk of violence and trauma for people seeking to acquire the drugs that they want to use. So, it's an evolving practice here, and we certainly started off on the wrong foot by providing people with something they didn't want really, which was hydromorphone tablets. Didn't quite work for a community that has a lot of experience with fentanyl. But, now we're moving towards providing different formulations of fentanyl for people, and it's being much better accepted. And people talk about how this has been transformative for them in terms of not having to spend all their time trying to acquire the money to make sure they have what they need to avoid withdrawal, not engaging in crime, and just having so much more time for other activities of daily living, including spending time with loved ones. So I think there's a huge opportunity here to learn from safe supply provision and ultimately to move towards a regulated model for drugs of all kinds.
So there are so many scintillating questions left in the Q&A box, but unfortunately, folks, that's all the time we have for today. Thank you so much again for joining us. Keep an eye out for more events in this series. On February 14th at 1 p.m. Eastern, we'll have activists who use drugs and harm reduction researchers and coordinators presenting on the concept of safe supply that Thomas was just talking about versus current drug regulation, as well as talking about safe supply in relation to racial justice. On March 14th, also at 1 p.m. Eastern, we'll bring together activists who use drugs to discuss their involvement in drug policy reform and harm reduction efforts, relating lessons learned through their advocacy experiences, and what a drug user-centric drug policy reform would really look like, tying in discussions of work and adjacent movements. And finally, in future spring sessions, we'll be hosting conversations on racial and other social structural inequities in drug treatment and harm reduction systems, deconstructing the brain model of addiction, and alternate ways of thinking about drug use, and all of that in 6 sessions, including this one. Thank you so much again for joining us today. Thank you so much to all of you panelists, and really appreciate all of you. Thank you so much for your work and everything you do.
Thank you.
Thank you.
Thank you so much.